I think that, first of all of us are, I think we're getting to know each other really well, and we love your presentations. So today's presentation, which is continuing this theme, we have the pleasure and honor of having the pharmacy students from Midwestern University with their professor, Dr. Don Gerber, presenting for us. And one of the things that they're going to talk about today is the thing I think that most of us always wonder, and something that they've touched upon to a degree in some of the other conversations, and that is, what is it? I'm paraphrasing what today's presentation is, but what does it entail to be a pharmacist? And which led into this conversation of why does it take so long to fill a prescription? Because as we've learned over these last couple of weeks, that you have to know so much. It's no longer about measuring things properly, but there's so much more other information that you really need to know to be a pharmacist today. And we have the honor today of listening to this topic, which of course will entail many details of why does it take more than 5 minutes to fill a prescription. So I'm going to share that honor with Dr. Don Gerber, and you can, of course, introduce your students who will be presenting today. Thank you.
Perfect. Thank you so much. So I think this is a great topic. And honestly, if you had asked me before I ever stepped foot in a pharmacy, what does filling a prescription have to, what details go into it, I would have never known. And I think this is a great topic to share with lots of people because, it seems like most people in their lifetime fill at least one prescription. And I know this goes through our patients' heads when they're standing there at the counter. So I'm introducing Sammy Ho and Janine. Oh my goodness, Janine, I'm so sorry. It just flew out of my head.
Leoncio.
Leoncio, okay, I was close. They will be presenting today, but all four of my Doctor of Pharmacy students, Sammy, Janine, Catherine, and Kyle and Catherine, you guys already know a little bit. They all worked on this presentation together, and I do need to acknowledge my teaching assistant for this course, Miss Tori Zizak, who will be graduating with her Doctor of Pharmacy degree this May. And she actually has over 20 years of experience in pharmacy as both a technician who's certified and she will be a pharmacist in May. So with that, I hand it over to Sammy.
All right. Hi, my name is Sammy, and I will be presenting this topic with my colleague Janine for today. So for our presentation, we will be discussing why does it take more than 5 minutes to fill a prescription. Next slide. Okay, so some common reasons. So first would be we get lots of phone calls. We get phone calls from different sources like hospitals, doctor's office, clinics, insurance companies, and even from other patients asking about questions. And then second point, we get lots of prescriptions, like a lot. Sometimes we get, 1 to 10 prescriptions per person at a time. We get them sometimes through the phone or in person. We get it from a lot of different ways, which we will discuss later on. And then the last point, most importantly, would be accuracy. So just like the photo, it's better to be safe than sorry. And then next slide. Yeah, there we go. So for this slide, it's kind of giving a quick summary about accuracy. So what is accuracy in a pharmacy? So we want to make sure that we are getting the right drug for the right patient at the right dose, for the right route, and at the right time. And also it's important to note that pharmacists are trying to improve health and not cause more harm. Next slide. All right, so this is pharmacy on the outside. Typically we see long lines. There's usually a line in the pharmacy, sometimes even at a drive-through. And oftentimes there's always a phone ringing somewhere in the pharmacy. Next slide. So earlier was a photo of how it looked on the outside. Now we're going to dive into more details about what it looks like inside a pharmacy. Next slide. Okay, so there are 3 stations in a pharmacy. First will be drop-off. Second is verification and production. And the third station is pickup. So we will discuss the first station, which is drop-off. Okay, so what is drop-off? So drop-off is where you drop off your prescriptions. And it's also where we verify and input prescription details, and along with insurance verification. So going off with the first point, dropping off your prescriptions. So like I mentioned earlier, patients come in with sometimes 1 to 10 prescriptions at a time, which can cause further delays. And then for the second point, when we verify and input prescription details, that's like inputting the medication name, the dose, instructions, any refills, and along with prescriber information. And then for the last point was insurance verification. So what that is that patients have a lot of insurance, sometimes medical, car, health insurance. There's a lot of insurances out there, and a lot of people get confused by it. Even sometimes I do too. So we need to sort through all of it, making sure we're billing your medication to the right spot. And next slide.
I'm just going to jump in here. So this is Dr. Gerber. This is also January, and in January, everybody gets new insurance cards, and there is no required standard format for insurance cards. So sometimes there are dates that the insurance cards are activated. Sometimes there's some people don't realize that they have new cards and they only bring their old cards. And so this is the time of year where pharmacy drop-off really can get backed up, where it may look like there's only 1 or 2 people waiting, but there's a lot more issues per person than what is the outgoing. So December and January are the crazy times at the drop-off window regarding insurance.
So yes, thank you for that, Dr. Gerber. Okay, so moving on to the next slide, which is that we receive a lot of prescriptions. So at a pharmacy, there's typically 4 ways of receiving a prescription. First will be hard copy or paper prescription, which is typically where the doctor would write out a prescription, hand it to the patient, and patient would walk into the pharmacy and give it to the pharmacist. And then the second one would be electronic, which is where doctor offices will input prescription information into their software and then send it to the pharmacy, which we will receive and then process that prescription. The third one will be fax, which is using a fax machine. And then the fourth point would be phone. So sometimes we do get doctors calling in a prescription, which is where they use a phone, call into the pharmacy directly, and then the pharmacist will write down all the information provided by the doctor. And then next slide. All right, so what are we verifying on the prescription? So the first point is legitimacy. We want to make sure that it is a real prescription. Second point is the patient information. We want to make sure that the patient's name, date of birth, phone number, and address are all on the prescription so that we know it is written for the right patient. And then for the third point, which is prescription details, such as, is the information provided on the prescription appropriate? So is it the right medication for the correct treatment? And are all the information on there appropriate? So for example, for people who are diabetic, sometimes they would need a prescription for their diabetic test strips. For billing to Medicare specifically, doctors do need to write on the prescription what type of diabetes the patient has. Sometimes doctors forget, and because of that, it can cause further delays in filling your prescription. And then next slide. All right, so here is a slide of some common insurances that you may have had, which is Aetna, Cigna, Humana, United Healthcare, and Medicaid and Medicare. So this is just a broad overview. There's a lot more out there in the market. So just be aware of that. And also, along with a lot of insurances, they all have their own coverage and restrictions. And next slide. Okay, so for insurance verification, we want to verify that it is the correct insurance. And is the drug covered under the insurance? Is the drug preferred by the insurance? Is there any additional documents that's needed for insurance? And sometimes patients come in with discount cards, trial cards, and supplemental insurance, which we can also add. And then type of service determines type of billing. So an example of that would be vaccines. So when billing vaccines, there is a different pathway to billing to your insurance. So because of that, that can cause further delays for the technician or pharmacist to find the correct insurance to bill to and the format of billing it to. All right, and the next slide, please. All right, so price, the big question. So like, why does my medication cost so much, or why does it cost so little this month? So we will discuss who determines the price. Next slide. Okay, so there are three possibilities. There's prescribers, insurance, and the pharmacy. So next slide. Okay, so it is definitely not the prescriber. So they are the ones who are actually just writing the prescription and focusing on the patient treatment. They want to prescribe the right medication for the diagnosis. So that's all they're doing. And then next slide. Okay, so it is not the pharmacy, because we are the one who are just following what the doctor wrote on the prescription, and we're just dispensing the medication to the patients. We don't decide on any of the pricing. So what is left? Next slide. So what is left is insurance. So they are the one who determines what medications they want to cover and how much they want to cover. So if you have any questions about why your payment is a lot higher than usual, it's important to give your insurance a call. All right, and next slide. All right, so what could go wrong at drop-off? So in this little bubble, there's a lot of things that can go wrong, such as prescription requires a prior authorization, and maybe prescription is not legible, or maybe the prescription was sent to the wrong pharmacy. And also to kind of introduce the prior authorization. So what that is that the insurance wants additional documents from the provider explaining why the patient needs a certain medication before they can cover it. So that because of that process does take a couple days, which can add further delays to filling your prescription. Next slide. All right, and then so moving forward with the other stations, my colleague Janine will take over from here.
Thank you so much, Sammy. We will now move forward with the next step in our process, which is called verification and production. Next slide. In verification, the pharmacist asks several questions to ensure the utmost accuracy. First, is this the right patient? This is verified through their last name, first name, and date of birth. Is this the right drug? The name of the drug, as well as its strength, must also be accurate. Is this the right route? Is this medication given appropriately? Again, as a reminder, an example of route would be by mouth. Is this the right prescriber? The prescriber is verified through their specific NPI or DEA number, as well as their practice address and phone number. Are there potential side effects? Does this patient need to be made aware of adverse reactions, or have they taken this medication before? Are there any drug interactions? Will this drug interfere with a patient's current medication therapy? And lastly, are there alternatives Sometimes a generic version may be appropriate and more cost-friendly for the patient. Next slide. This is an example of a written prescription that may be presented at the pharmacy. At the top, you can see that the prescriber information is accurate. The information that we have is the name of the prescriber, their DEA and NPI number, the phone number, and their practice address. The patient information is also accurate. We have their first and last name, their date of birth, an address, and a phone number as well. However, when we look at the medication, we can see that what's correct, though, is the quantity or the number of tablets dispensed, as well as the directions. However, we have a missing drug strength as indicated with the red circles circled around the amoxicillin. So we're missing our drug strength, as well as a prescriber signature also circled at the bottom. So as a result of these errors, the provider will need to be contacted to produce another prescription with the appropriate information. So this could take 24 to 48 hours or maybe more, causing delays in filling your medication. Next slide. In production, your pharmacy team works diligently to ensure that your medications are filled properly. First, the correct medication is selected from the shelf. Second, the prescription is filled or counted after the computer system approves that the NPI or the NPI, the number, I'm sorry, the NDC number, thank you, Dr. Gerber. NDC number matches with that of the medication hand-selected from the shelf. Sometimes the quantity counted can exceed 100 tablets, which can cause further delays. Third, the appropriate container is selected. So some medications do require special storage requirements. So an example of this would be amber vials to protect the medication from light damage. And fourth, proper labels at this stage are fixed to ensure the patient is made aware of certain warnings. An example of this would be a storage requirement, like keeping this medication in the fridge or being sure to take this medication with food. And lastly, fifth, the pharmacist will undergo their own approval of all the parameters listed previously before packaging up the medication for pickup. Next slide. Here's a chart that highlights a few major setbacks that can occur during production in regards to out-of-stock drug shortages. There are several reasons why a drug may be out of stock, rendering the pharmacy unable to fill your prescription. So some major reasons include a shortage of raw materials, delays due to quality approval, and manufacturing issues that halt production as a whole. Another reason would be recalls. They can cause delays during production at the pharmacy, where the manufacturer takes back the product due to potential contamination or other errors, making it unsafe for use. Next slide. The last stage in our process is called pickup. Next slide. Here, the patient has been contacted and arrives to the pharmacy to pick up their medication. The first thing that happens is the patient is verified using their last name, first name, and date of birth. Second, the patient is offered a consultation with the pharmacist, should this be a new medication or if there are any drug interactions that need to be relayed. Some other tasks that the pharmacists perform at pickup include vaccinations. Our database can track your vaccination history and offer one if it's due and if the patient wishes to obtain one that same day. Also, over-the-counter recommendations can be provided. Sometimes patients may have questions on what to take for self-treatment. Pharmacists have a wealth of knowledge that can direct patients toward the best product for their ailments and even recognize if a condition requires advanced care with their primary physician. Next slide. So even with this plethora of duties assigned to the pharmacist throughout each stage of the process, we are always here to help you reach your optimal health goals. Next slide. And that concludes our presentation on why it takes more than 5 minutes to fill a prescription. Thank you so much for your attention.
Thank you for that presentation. I already have a couple questions that have come up, one of them through Facebook and then a couple in the chat itself. But so on the first question is really about, is there a difference between Europe and America? Because there's a woman who watches from Luxembourg, and she wrote to me privately in WhatsApp actually, that she gets, anytime there's a prescription, they come in a box. It's a closed box, and there's always extra. So let's say you needed 10 pills, there's typically 15. So I'm wondering is that just country to country? Like, how does it work typically? Have you ever researched this?
Not personally. I do know that we don't give extra, especially for controlled medications. It's definitely a lot more regulated, but I'm not sure what the laws would be in Europe or any other.
Like, she even wrote that, I've seen, and many of us have seen, when you get a liquid medicine, you'll watch in the pharmacy that they're filling it up exactly with the exact amount of water or whatever has to be put in there.
That's
They
true.
get it as powder and are told to do it themselves at home.
That is true.
Oh,
Well,
interesting.
sometimes, well, go ahead, Sammy, go ahead.
So at my pharmacy, sometimes for liquids, we might give a little bit more just because sometimes patients might not measure it correctly, or let's say if they spilled some, we just want to give them a little bit extra just in case if something like that happened. And then in regards to suspensions, we typically fill it at the pharmacy, but if the patient requests to fill it on their own, we do allow that too. We cannot, we can do either or. So it's really up to the patient's preference.
Why would they do it on their own?
So like, let's say, so once we put water into the antibiotic, it's only good for a certain amount of time. Sometimes, let's say patients are traveling somewhere that could, last more than 2 or 3 days. You want to travel somewhere far. Then they can dispense the water on their own at that location that they're at.
Okay, that makes sense. I'm wondering, one of the things that I understood from her was that the boxes are already prepared. So maybe that's why you're getting 15, because another dosing might have been 15. Meaning they're not counting it and putting it into a bottle. They're taking a box and handing it to you. That's what she understands. So maybe that's part of it, but I understand what you're saying as well. Why would they give extra pills? Yeah, Dr. Gerber.
So I will say that we are probably the most regulated medical pharmacy situation across the whole world. So I'm sure everybody knows in Mexico, you can go get whatever you want to go get from the pharmacy in whatever quantity you want. And in other countries, actually, so I had the experience of being in Rome, Italy, and I had a sinus infection, and they have nothing in the OTC aisle. And I remember the Italian pharmacist was trying to counsel me on Sudafed. And I thought that was very nice of her to try to, in broken English, try to counsel me on that. But I could request anything. So a lot of countries have different things. We have OTCs, and you can take anything you want without talking to anybody. Other countries have everything behind the counter, but you can request it, but the pharmacist has to approve it. So every country has a completely different system of doing things. I would say that our system is definitely the most strict, and we're also held the most accountable. So that's another reason that we probably have the most strict system, is that if something does go wrong, there's no like, oops, sorry. In the United States, pharmacists are held to pretty high levels of standards, and mistakes are not tolerated.
Okay, and then another question that was brought up is, I noticed in the flow charts that you shared, one of the things that you said is this the correct medicine for what this person has? How would you know what the person has? Do you know what I mean? Like I've seen prescription papers. I don't know what comes in when they do electronically. I've never seen the ailment. I've seen really bad handwriting saying, 500 milligrams of amoxicillin, 10 to, I don't know what it says, but it doesn't say that this kid has strep. You know what I mean?
Yeah, so that is an issue. And Kaiser Permanente, if anybody's familiar with them in Colorado and California, they are what we call a closed system. So they own their pharmacies, they own their hospitals, they own their healthcare providers. Their prescribers are actually required for the prescription to be filled at a Kaiser pharmacy. They have to put the indication or the reason on the prescription for two reasons. So Kaiser did a bunch of research more than 15 years ago that showed that the error rate went down. So patients got the correct medication for the right reason. When the pharmacist had that information to go, oh, amoxicillin for blood pressure? I think maybe you meant to select amlodipine for blood pressure. So there's that great double check aspect. Whereas in the United States at a community pharmacy, if they didn't put what the reason was, we would never know that, oh, they're supposed to be getting amlodipine, not amoxicillin. So Kaiser actually does require their providers to put the indication on there. And then the second reason that Kaiser requires their physicians to put the reason for the prescription is because they did some more studies and showed that patients had better outcomes when they knew why they were taking their medications. In the community world, in the non-closed system, pharmacists are trained to ask the patient, what are you taking this for? And when I used to work retail, when I was a pharmacy student 15 years ago, we did find errors by asking the patient, oh, what are you taking this for? And the patient would say, oh, blood pressure. We're like, amoxicillin for blood pressure, that's not correct. So there is a push to that should be a required component of prescriptions. It is considered a best practice for physicians to put the reason, but it is not a legally required situation. So pharmacists just have to ask.
So in your, just to follow up with that, in your work behind the desk at a pharmacy, and this is probably also for the students who do internships with that, have you found or seen some really bad mistakes because of that?
If I can interject here and add a little bit. So along with what they had said, and Dr. Gerber just mentioned, when a patient brings in a prescription and it's not maybe necessarily noticing their ailment that they're presenting with, but when we're doing that initial verification process and we can pull up and see a history of the patient. And maybe this patient was on, we'll just go with amlodipine, as Dr. Gerber had mentioned. Maybe they were on 5 milligrams, and today they're presenting with an amlodipine 10 milligrams. And we're going to go, oh, are you aware, Mrs. Smith, that your dose changed? And so many times they are not. And so it prompts a call to the doctor's office to say, did we realize that we had selected maybe the wrong strength or put the wrong strength down, depending upon maybe if it was sent in electronically, like Sammy had mentioned is a way to do that. So there's all different aspects that we need to verify that the prescription was right for the patient. And sometimes the patient will present and go, I haven't been on this prescription for a couple months, but they included it with my refills when I went for my visit today for my checkup. So we'll call and realize, oh, they haven't been taking that, it was replaced. So there's just a lot of different reasons why that could be. And so we're always looking at everything to make sure that the patient's getting exactly what they're expecting, when they're expecting it, or maybe they were expecting a medication and it was not called in. And, especially if they might have a list of medications they're normally on. So that would then too prompt a call to the doctor's office to say, oh, we're just missing one other medication. Maybe they need their furosemide or something like that.
Thank you.
Mm-hmm.
And then I guess this is a question that a lot of us want to know. And Tori, you might be the one for this, since I understood from Dr. Gerber's intro of you earlier that you've had a lot of experience even as a tech. Why is it
Yes.
that the published price, even maybe with insurance, would be a certain price, and then you now have this amazing app, GoodRx,
Yeah.
that can literally drop a price by hundreds of dollars?
Yeah, that is a good question. So as Sammy had mentioned, when it comes to insurance, insurances, depending upon what kind of insurance you are, a lot of them now have what we call tiers. And they will say, okay, we're going to cover this medication first for this copay. And then if the patient fails or doesn't respond as we'd like them to, we can move to a different tier, that next tier up. In the case of GoodRx, and I worked at Fry's recently, and I can't even tell you how many patients had healthcare insurance, but it was just way cheaper to go with GoodRx. So I believe, in Dr. Gerber, maybe you have more you could add, but I believe what happens is these different manufacturers, in particular with GoodRx, Fry's, Walmart, Walgreens, they all have contracts. And you could have lisinopril, right? A blood pressure medication. It has to be the same strength. We'll go with 5 milligrams. And then it would have to be a certain quantity. So we'll say 30, a quantity of 30 versus a quantity of 90. You can't vary your quantity. They will say, okay, we're going to cover it for like $4 or $12 right now at Fry's. However, that can change. It could then go up in a couple months and now it's cheaper at Walmart. So I feel like it's all this competitive nature of, trying to help the patients out, but at the same time, these are large companies that are bought in to have, I hate to say it, a piece of the pie. It's the same thing with the insurance. The insurance decides what the patient's copay is going to be. And unfortunately, I've just seen it so many times. The patient comes in and goes, my copay was $20 last month. Why is it $35 today? And I really don't have an answer. It's all up to what the insurance wants to charge the patient. And I will say the patient needs to be their biggest advocate. I think one of the best things that I've learned being in healthcare is being an advocate for me and my family and my friends and, people that I know, to really understand if the copay is really expensive or it's higher than it has been. Don't be afraid to ask, what's the cash price? What if I don't use my insurance on this? There are often times that it might cost $9 for a prescription, but your copay was 10, 15, 20. So just always keep that in mind. Do not be afraid to ask. Your pharmacist is your friend in the matter. We do not want to charge you, all the money in the world. We want to make sure you're taking your medication and you're getting the treatment that you need instead of going, whoa, I can't afford that. And along those lines, just to add, I know there's a lot of times patients do struggle with, being able to pay for their medications. So there are discount cards out there that doctors' offices have for patients. There are the options of GoodRx, and then you can, pick up a couple days supply at a time. I hope that answers that.
So I think to clarify a little bit, I think you touched on like the insurance side of things, but GoodRx is a good discussion point. And so Sammy or Janine, if you guys have experience with GoodRx, what do you guys know? What's your experience with that?
Not much experience with GoodRx, quite honestly. Hopefully more as the years go on. But
So for me, I don't know behind the scenes of GoodRx, what the company is, what their contracts are, but I have worked with a lot of people who come in with GoodRx, and I think it's a great accessibility for a lot of people. You can just go on your phone, look it up, type in the medication name, and it generates a coupon for you. It's really quick, really simple. But again, it does vary in how much they cover, just like insurance. Sometimes it is cheaper with GoodRx, sometimes it's cheaper with insurance. But like with what Ms. Zizek said, don't be afraid to ask pharmacists to check prices for both your insurance and GoodRx, and then pick the cheaper price. I do that for a lot of people, and I'm happy to help with anybody.
So can I ask you guys a question? Is there on an ethics perspective, like as a pharmacist, when you see, okay, they're paying $10 or whatever, or maybe 50 to 500, and you know that they should be checking GoodRx, are you allowed to tell them, hey, by the way, you should really look in, that's not an issue on the perspective of who you're working for?
Absolutely. Mhm.
I will
We will-
say a caveat of this, and I haven't done the research into GoodRx, so this is just what I have seen in previous years, is that no one does anything out of the goodness of their heart in business.
It's funny that you say that. While you're talking about that, I'm looking to see on their website if there is like, what's their inspiration? Is it because, oh, I paid too much and my parents paid too much and therefore I created this free application? And in fact, the last thing on their help section is if you're interested in working with GoodRx, please send all business and partnership inquiries. So clearly it's a business, but
Yes.
you're saving people a lot of money.
So
Yes.
the thing of that is though, is there's different, just like insurance companies have different tiers, there's different levels of GoodRx.
Right, I see.
So
GoodRx
there's the free GoodRx that you can use like one time, and then there's a GoodRx you can pay like $100 a year. I don't know all of them, but I know I was helping patients all day, every day at Fry's with GoodRx. And if somebody came in and they're like, oh gosh, that's really expensive, I would suggest GoodRx to them, whether, even if they had it or not. And if I saw in the system that their price seemed a little high, I would run it by myself just on the various different insurances to get the price down for them, or make sure that the price that they were left with when they came to pick up was in fact the best price. So yeah.
That's you being nice.
Yes.
So here's some piece of information is they do sell the information. So
Okay.
they collect that information. They are not a healthcare provider. They are not bound by HIPAA because they are not a healthcare provider. And so when you do use GoodRx, there is fine print that they are going to sell information. Now they say they do not sell your information in the sense of Dawn Gerber got amoxicillin on, Wednesday, January 27th, but they are collecting your information and they are selling it. That's a piece of how they make the money. The other way they make that money is the fact that they negotiate contracts just like everybody else. And there is some concern in the pharmacy world that they do not include payment for dispensing fees, is my understanding. So traditionally, when an insurance company presents with a copay, part of that equation is cost for the drug plus a dispensing fee plus a fee. And don't quote me because I have not done enough research on this, but my understanding is that they undercut the fee to the pharmacy. So that is a little bit of a concern, is that you can't.
So it's not accurate pricing?
Yeah, it doesn't reflect everything that goes into that prescription. So for instance, this is just an example. My husband manages a pharmacy, and they discovered when they ran a report that they were contracted with this company, not GoodRx, but just another company. And the way the contract had been written, every time that they dispensed a prescription or a patient picked it up from that pharmacy, they were actually losing $2 on every prescription. So you can't have a model that is sustainable from a business standpoint where you are losing, you're not making money, you're going backwards actually. So in essence, almost giving the patient $2 every time they came to your pharmacy. They ended up closing. Just not.
It's interesting that you say that, because I, thank God, don't do a lot of prescriptions. But my grandparents used to live here for a bit, and they were from Argentina, and they didn't have insurance here. So we would pick up their prescriptions here. And I do know that sometimes it was a coupon, but sometimes we used it just to find out which pharmacy had a cheaper price. So it wasn't a coupon. It was like over there at Walmart or at Fry's, it's $4. And if I went to Walgreens, which was near my house, it's $33. So in that regard, I guess it wouldn't be the issue. It's more about when it's with a coupon, I assume, which means that there's some sort of a contracted price.
Yeah. And you talk about why is the same medication different costs depending on where you're going?
Yeah, that's a good question.
Different pharmacies have different contracts. So Walmart is huge. Sam's Club is huge, and they are able, whenever you buy in bulk, you're going to get a better buy, right? So like anytime you go to Costco, you're going to pay, you're going to buy a big old pack of toilet paper, and it's going to be less per toilet paper roll.
It's a myth. That's a myth. People think that it's better pricing, but it's not always.
It is.
It might
All right,
be better quality toilet paper, but that's another conversation.
When you buy in bulk, generally it does cost a little bit less. And so we do know that companies that have big buying power can offer things at a lower cost. Other times there's just things that go into the system of costs that, we on this level as pharmacists can't necessarily explain why something would be $6 at Sammy's pharmacy and $10 at Janine's.
Well, it's kind of like what you mentioned, though, negotiated pricing. So depending on where they're getting their supplies. I have a private comment in here that as a retired pharmacist for over 60 years, so maybe you should have him present to your group. Discussion at the window helps in relaxing the patient as well as determining the prescription accuracy and dose, which was what you had referred to earlier. So I guess that's our checks and balances, is if you have that consultation, okay, what are you going through? Is this good? Do you have any questions? But I'm sure that many of us do use, I mean, again, the most I get prescriptions for is like strep and stuff. I have little kids. But I'm sure as you get older, those are important conversations.
Yeah, I would encourage my geriatric patients, never decline a consultation at the pharmacy window. You will always get some good information from that conversation with the pharmacist. And most of our pharmacy students, Janine, Sammy, Tori, why did you go into pharmacy? You wanted to help people. You wanted to talk to people. That's what they want to do. Nobody says they want to go to pharmacy school to look at, contract prices. They want to talk to patients. That's
why they own pharmacies, not right. That's when they own a pharmacy, they want to talk about the contract.
Right. Yeah. And you're going into MBA school for that. Rabbi, did you see the comment about sometimes the prescription electronic transmission gets delayed over the internet? Do you want me to address that?
Sure. Yeah.
Okay. So Judy wrote, sometimes the prescription electronic transmission gets delayed over the internet for some reason. This definitely happens. And that is the computers talking to different computers who speak a slightly different dialect than the other computer. Sometimes things just get lost in cyberspace. I know that happens. Sometimes the prescriber picks the wrong pharmacy from the pull down menu. There's a lot of pull down menus in the prescribing world. So me as a pharmacist, I can prescribe at my practice site, and there are so many pull down menus to choose from. And sometimes the pharmacy pull down menu just gets picked incorrectly and it goes to, pharmacy A instead of pharmacy ZZ. And that can definitely happen. And so I think, and Sammy and Tori, correct me if I'm wrong, but when electronic transmission went into play 15 years ago, it was really dramatic, the delay. We're talking like 24 to 48 hours sometimes. But Sammy and Tori, have you guys had a different experience? Hopefully 15 years later, that has improved?
Yeah, I think so. I do see some delays sometimes, but not 24 to 48 hours, not that long. I want to say no more than 3 hours if the doctor did send it, though, because sometimes doctors go on lunch and then they'll send it after lunch. So sometimes just be aware of that, which can cause delays. So once they send it, I want to say no more than 3 hours we'll receive it.
Yeah, I think
I
that's
agree.
definitely improved.
You
50
you
years.
mentioned one thing that you said that you can prescribe as a pharmacist.
I can. It's called a collaborative practice agreement.
What can you prescribe? Just
Uh,
Okay.
I do various medications or various collaborative practice agreements at my practice site. So for the one we're doing the most right now with Tori is warfarin or Coumadin anticoagulation to prevent blood clots. And so I have a collaborative practice agreement with the physicians at my facility. And we poke the patient, we get a blood sample, we test that blood sample, and then depending on that blood sample, we adjust their dose of warfarin. And so I have that ability through that collaborative practice. Just a little pat on pharmacists back. There's a lot of studies out there that prove that pharmacists do the best job of managing warfarin dosing. We have more
100%.
time in range and things like that. We have collaborative practice agreements to adjust blood pressure medications. So we see the patient in the office, we test their blood pressure, and we can adjust their blood pressure medications. The other pharmacists at my site do diabetes management. I have not gone through the computer training for that yet because of the pandemic. But the other pharmacists at my site, they test the patient's blood glucose levels, their A1Cs, and adjust their diabetes medications. We also have a collaborative practice agreement for determining cholesterol medication. So we also, actually, I can prescribe smoking cessation prescription medications as well.
So are you, that's actually really fascinating. Is that typically why you see now at some of the larger pharmacies, they have like a privacy booth where they can kind of do a health assessment of people? Is that more for these types of things?
So traditionally, if you are in a collaborative practice agreement, you have to be in the same building as that
okay.
prescriber. So for instance, I don't work in a pharmacy. I work in a primary care doctor's office. But what you typically see, those private consultation areas are for like vaccinations and other specialty medications at the community pharmacy level. But you see a lot more clinical pharmacists in physicians' offices doing the types of services that I provide. So I have not worked in a community pharmacy in 17 years.
Lucky you.
I do enjoy not standing on my feet and being able to spend time talking to my patients and things like that.
All right, that's okay. That's pretty cool.
Yeah.
I see that Ethel, or you have a question, Ethel? Go for it.
I don't have a question. I say that patients have to be their own advocate. My husband was prescribed a very common, I remember now, a common medication filled before surgery, and the insurance refused. So somebody else would have just said, well, okay, I'll pay for it. But I called the insurance company. I said, you're refusing this. The doctor ordered it. He's going to have surgery. Oh, that's a different story. And they approved it. Or if a medication's too expensive, you can go back to the doctor and say, hey, what else? What is a substitute? What else can I have for the same problem that might be cheaper? So you have to advocate for yourself. You can't just go along with what the insurance company says all the time.
Absolutely. So I used to sit on a nonprofit Medicare program, and we were on the board to determine which medications were at what levels and things like that. And every insurance company has different preferred items, different prior authorization materials and things like that. And just like as pharmacists, we don't have the insurance company copays memorized and things like that. The prescribers don't either. So how many people take their formulary to their doctor's office every time they go to a doctor's appointment? They take their formulary from the drug list from your insurance company.
I do.
So I have a question, something that was mentioned, and then Stan, definitely speak up in a moment. So you can't prescribe, from this conversation that Ethel mentioned, you can't change someone's prescription to another medicine. What about from brand name to generic?
Yes, so we can.
Okay.
Yep.
So you just wouldn't be able to go to a totally different medicine for the same problem, but you could change from brand name to generic.
Correct.
Okay. All right. I think Stan has a question or a comment.
Mention two things that happen. We have mail order prescription for my wife's plan, and we get 3 months supply. We pay for 2 months. And I was getting a medication that was 3 months supply was $20. And I called in and they mailed the prescription. And once you, in a sense, take it out of the pharmacy, you just can't bring it back. It's left the pharmacy. And I got a bill for $200 because it was no longer within the plan. And I called them up and I said, when it changes from $20 to $200, don't you think I should be informed? And they said, I could keep, I said, I would send it back to you, but you won't take it. It's not legal to go back. They said to pay $20 for it. And I paid $20 and I called the doctor up and never took the prescription again. The other one I had was where I have a nasal spray, and the nasal spray says 2 sprays in each nostril, but you're only entitled to 11 sprays per day. Now, I don't know how you figure 2 sprays in each nostril and get to 11. I had to have that prescription rewritten about 5 times before they would honor it within the plan.
So Stan, if I can address that. So, when you talk about, $200 and $20 the last time, that's once again coming from the insurance company.
Yeah.
And when I mean, man, and we just, my family and I just went through it back in November, trying to decide if we wanted to put our family on my health insurance through my employer or my husband's health insurance through his employer. Being pharmacists, we sat down and we read everything in that fine print of what his plan offered and what my plan offered. And that fine print says that you should have, that you have access to your formulary and that you will know that you know what you're getting. So the pharmacy doesn't have that information, your formulary, you have that information. The bad thing is, and this is a real irritant for me, is the fact that a lot of insurance companies no longer mail you that book. Like I remember in high school in the 90s, my dad's insurance, they would mail him a book that was like that thick. And we would take that to the doctor and he would say, okay, I need to give you an antibiotic. What's covered? Now, a lot of insurance companies send you a postcard. It looks like junk mail. And it says, if you want a paper copy of your email, go to this web address or call this phone number. And a lot of people ditch it. But honestly, taking a copy of your formulary to your doctor's office would make a huge difference in being a good patient advocate. You may have to call the 1-800 number at the back of your insurance card and request a paper copy of your formulary so you can double check, if my doctor is prescribing me this nasal spray, what is the cost going to be? The insurance has to give you that information. The thing is, no one says how they have to give that to you. They just have to have it available to you. So yeah, that is very frustrating, but we don't have access to that information. And the pharmacy assumes if you're using that insurance that you have signed on the dotted line of, yes, okay, so, this is going to cost $200. It is. It's an awful system. And I feel very passionately that you need to opt out of getting the printed instead of opting in to get the printed version, because it would make things a lot smoother. You take the formulary to your doctor, they pick the pharmacy, there's no surprises then.
Well, now that it's straightened out, I just tell them, contact the pharmacy and tell them to renew that prescription, period.
Yeah.
And that solved it. But when it went through at one point, it was a joke.
Yeah. Rabbi, did you want me to there was a question in the chat. Did you want me to address that?
Sure. I mean, you definitely can. I think Sammy had written back.
Oh, did you? Oh, my apologies.
Did you, Sammy? I think it was, what question are you referring to? What's the value of the birth date?
Yeah.
Like the verification part?
Yeah.
I mean, you could
and maybe
address that.
Rosemary can clarify what you mean. What's the value of the birth date?
I just asked her to unmute. Hold on. There you
It seems like everywhere you go, that's the first thing they ask you. And sometimes, even at the doctor's office, when I call in for an appointment, they ask for my birth date before they even ask for my
Well,
name.
Dr. Gerber, can I actually answer that? Because
Yeah.
I'll tell you why. I have a daughter. Her name is Mushka Levertev. All right. My brother has a daughter. Her name is Mushka Levertev. If we don't use the birthday, there are a lot of problems. So they might have a patient that is another Rosemary Isaac. That's very, and by the way, we've had that, issues like, oh, your daughter. I'm like, no, that's, what birthday are you talking about? Wrong person. So that's your short answer. They want to make sure it's you.
Yeah.
I think another answer is that it's reduces the database quite a bit if you put the birth date in first, rather than a common last name. And I always give the birth date first and then the name.
The other thing with that is when we get a date of birth and search, just like you just mentioned, it reduces the database. But also, if we start searching by last name, I know in retail there were several times that maybe I didn't understand how they were spelling the name. And so I was not pulling up the right patient database at all. But when you get a date of birth, it does limit it quite a bit.
Bradley, I'm not sure what you addressed the issue of twins, both of the same gender. What is that?
A new prescription is being brought in for one twin. Both are male, both have the same birth date, and the insurance refuses it because it's a duplicate that you filled for the other child yesterday.
Okay. By the way, he is the retired pharmacist of 60 years. So, Brad, you probably have gone through this issue.
Many times.
I guess that makes you make a phone call. It's like, no, that's legit.
That's correct.
All right. Any other questions? I know this was a lot of information, of practical knowledge of what's going on behind the scenes.
As always, a superlative job.
Oh, thank you. Thank you.
All right. So thank you very much. I know that everyone's going to be excited. We do have another presentation with them, and that's going to be more of a practical conversation about what's the difference between, I think it was fish oil and Lipitor, right? Is that the correct? So that is going to be next month because we begin February next week. And so again, I want to thank you all. Always a great presentation, great job. I'm looking forward to one day, and many of us probably bumping into you at one of the pharmacies. If you don't move back to your home states. But thank you.